Okay, so we stay lingually, like in the mouth. So the first incision will be, as we did before, a normal single incision. You can measure before if you want. For example, we want to obtain 1 centimeter of epithelial connective tissue. We measure with the probe. We measure with the probe 1 centimeter, 10 millimeters. Okay? And then we go with the blade. Okay? Then, when you obtain the first incision, you can do the second and the third. Okay? If you want to do that, do you prefer to do that now and then I go to the next step, or you want to see the next step and then do all alone? Let me try to do these 3 incisions. 1 centimeter length. Mine I obtain a little bit more than 1 centimeter, and then 2 vertical incision of 4 millimeter. Okay? In this case, we will stay a little bit superficial, so try not to go too deep. 2 millimeter, only with the tip of the blade. Okay? Like this. And remember that during this procedure you are perpendicular to the long axis of the tooth. Imagine that this is the palate, so I am perpendicular to the long axis. Because only after this procedure I will go parallel to the long axis. But now I am perpendicular. 1, 2, so 1, 2, 3. Try to do that, and then we will start the next step. Thank you.
Would you like to have a chair? To sit? I bring it.
No. I take it. Don't worry.
Then we have to change the table. Tämä tuli aromaattamista. See, I upset them. We have to change it because this here is the blade. So maybe.
Yeah, probably it's better. So. Thank you very much. Okay. Are you ready for the next step? Okay. So now imagine that this is mesial and this is distal. You start modifying the direction of the blade and you start going a little bit deeply. Okay? But look my blade. It is a little bit superficial. I don't know if I'm able to... Okay, look at the quantity of the soft tissue here, as I show you. It's 1.5 millimeter. Okay, so go deeply with the blade from mesial to distal, as you can do in the palate of your patient. You arrive at the end, okay, and then you can do it in the opposite direction. The most important thing is to arrive with the end of the blade at the length of the vertical incision. You have to be here, because if you stay a little bit shorter, then you are not able to remove it. Okay, so don't be afraid to go deep and maintain exactly the same direction to obtain a correct quantity of the tissue. Not 2 mm at the beginning and 3 mm of thickness at the end. Try to be really precise. Do this step and then we will remove. Do you need some help to maintain the lower jaw stable? If you need help, I'm here. Or here. Yeah, perfect. But you don't have to be afraid. You see that here you need to cut a little bit more, and also here. Don't be here. Deepest in the sense that you have to go a little bit more deep in that sense, not in that. Okay. Perfect. Okay. So at the end you can this is 4 mm deep with all the length. Okay, you can see it with the probe, you can try, and this is 4 mm deep in terms of horizontal direction. And the probe doesn't interrupt, as you can see. If you feel some interference, you have to cut it out, okay? Because at the end, when you go to do the fourth incision, you can perfectly cut it out. If you have a little bit interference, you can cut it. Okay, and as you can see, the thickness of the tissue is the same from the beginning, which is coronal, to the end, which is apical. If you find a sort of triangle, is not in terms of thickness, I mean, is not correct, it means that when you were like this, you have modified the direction of the blade, because if you maintain the blade in that direction, you obtain a perfect thickness of the tissue. But if you move like this, you obtain in the coronal part 1 mm, in the apical part 3 mm. And it's not the same, because when you try to put it inside the vestibular flap, you obtain a different thickness during the flap, and it means that the aesthetic result at the end is not homogeneous, and it makes a difference. So when you finish and you obtain this epithelial connective tissue graft, we do the vestibuloplastic.
my cheeks very thin. I made this kind of, but this one too thin.
Yeah, but no problem.
No problem.
Yeah.
And this was the first, the second.
Perfect. It's absolutely perfect because you have a really thin tissue there, but it's okay. The most important thing is to try to maintain the same thickness from the coronal part to
When you
the
start
apical
with
part.
this final
Yeah.
incision, will you start from this and then go deeper, or will you go already 4 millimeters?
I do like this. I start mesially
Yeah.
with imagine half of the blade I need, and I go distally. Okay, so I can use the forceps to restart distally, go out of my depth and go mesially. At the end I finish and I do the fourth incision. Because in the mouth, at the beginning, you don't see exactly what you are doing with the first changing of the incision. So go, I don't know, 2 millimeters, okay? Then take the forceps, a little bit elevate, and then you can go deeply until the end of the depth you need. And then you remove it. If you want, just to explain this part, okay, just to explain this part, it's really simple, but it's part of our training. So the suture of the sponge, can we have one suture, please? Normal suture. Thank you. Thank you very much. Imagine to have the sponge inside, okay, like Spongostan or whatever you use. So you put it inside the sterile water, okay. Then here you put the sponge, okay. If you use Spongostan, for example, you cut it into the middle and you use only half of the sponge and you put it inside. The blood blocks the sponge, so the sponge is stable into the wound, okay. So now to fix the sponge, you can do like this. Imagine to be apical here and coronal here, okay. So start in the distal apical area, you do like this, you re-exit in the same part, okay. You can start also a little bit closer to the beginning, okay. Okay, we can do everything because I have the best assistance of Estonia today. So we put the sponge. The sponge starts to be covered by the blood. Fortunately, the pig is not bleeding. Then we start distally, okay, at the end of our wound. We exit 3-4 millimeter mesially. Then we go coronally between, imagine to have the molar here, between the molar and the first incision. We re-enter distally and we re-exit mesially. And so at the end you can close the cross suture like I showed you before. So 2, 1, 2. Okay, you can do 3 of them or if you have a little bit shorter wound, 2 of them, and you block the sponge. So from this point you can go vestibulary to do the vestibuloplastic. Don't put it away because
Ilona.
when you have done the suture, we can start the vestibuloplasty.
Exactly. Is exactly what you have to do with your patient. It's perfect, no worries.
Without vestibuloplastic, if you need both hands for the instruments, then it fix the picture, then you can tell me.
Yeah.
And
Of course.
if there is need, if you need both hands to use.
Thank you. Yeah, imagine that in the mouth it is full of blood in a pair of seconds. It is absolutely stable, and if there is too many blood with I don't remember the name in English, the garza, just to push and to block the bleeding. Compress, yeah, you can compress, and in 10 seconds it stops bleeding, and then you can start suturing.
Do you have some special point also where to compress, a little bit palatal distal, or
No, exactly in the middle.
like the same place in
the
where
middle.
the
Or you can
places
do distally because the
the
blood
blood,
arrives
yeah.
from the distal part.
Neli viimast läheb loosi. Need on 2 viimast. Need tuleb tänulikult jagada. Järgmised plastikad kas teise õmblusmaterjaliga plastikat kinni panete, et siis läheb sihukest hoidus. Üks on veel, näete, üks on see just ees peitus. Millel oli vaja? Ei no, üks pakk on veel, aga siis ei ole teemad lihtsalt. Teil oli soov ühte kindlas materjali seda plastika, mis te nüüd hakkate vestibuloplastika kokku õmblema, et näpud ei saanud. Et kõik saaks ikka ühe seda seraleeniga või ühe korra üheselt seda ära.
There is another box of...
Yeah, I was just telling that for the plastics it's one for that was meant.
Okay, are you ready for the vestibuloplastic flap? Okay, so now
välja lõikasin, aga ma ei tea.
äkki on sul selle sees, võid rahulikult vaadata.
you lose your connective tissue. Okay, so now we have to work in the vestibular part of the tooth. So we have to work between the cheek of the pig and the teeth, like in this region. Okay, everyone understand what is this region in their mandible? I can show you. We need to work we have work in this region. Now we need to work here. Okay, so we need to work where there is the cheek, in this region. Why? Because you have keratinized tissue and also alveolar mucosa here. Okay? So I will show you the video. It is exactly in this region. Now I show you. Okay, so keratinized tissue, alveolar mucosa. We stay in the alveolar mucosa because it represents the case in which we have no keratinized tissue in the mouth of our patient. So imagine to be in the middle of the crest, so you can do the first incision. For example, if you have harvested 1 centimeter of connective tissue, you do this line of 1 centimeter, and then you do the second and the third incision, as I showed you before. You go deeply for 4-5 millimeters. It depends on what you have obtained from the palate. This is split elevation of the flap. The blade is going parallel to the bone, and if you pull the cheek of the pig, you can see that the movement of the alveolar mucosa is going a little bit apically, because remember, we want to obtain this free space in which we will put the epithelial connective tissue. But be aware not to cut the periosteum, because remember, at the end we need to suture this periosteum to obtain the apicalization of the mucosa. So the needle, as you can see, go down under the periosteum. Here you can see perfectly, and only with this type of suture you can fix the mucosa in the apical zone. If you are not able to go under the periosteum, you are not able to fix it. The suture moves with the mucosa and it's not correct. We need to go deeper. You can see perfectly there. You need to go deeper to go under the periosteum, and then when you close, you can pull down the mucosa. So also the third one, this is one of the really difficult suture to do, because it's not simple to go under the periosteum. Sometimes you need the 2 steps to go. But I want to underline, it's necessary to maintain the periosteum here. If you elevate the flap with the full thickness with the elevator, you remove the periosteum, so you are not able to fix this type of suture, and the mucosa go up, so it doesn't work. Okay, now we have a vertical space in which we can put the free gingival graft. Otherwise, you don't obtain this space. Okay? Do you want to review it? Is it okay? Okay. So, if you have obtained, for example, 12 millimeter of free gingival graft, do the first incision in the mucogingival line of 12 millimeter. If you need help to maintain to stabilize the
incisions should be longer than the graft.
Yeah, absolutely. Because otherwise, in the mouth, you do the incision and you know how much keratinized tissue do we need from the palate. Okay. So if you have, for example, a distal area from the second premolar, we need 15 millimeter. We go to the palate, 15 millimeter of the graft, then we go down 15 millimeter of the incision. Okay. So the 3 incisions are perpendicular to the long axis of the tooth, but then to elevate the flap, you need to go parallel to the bone. If you don't go parallel to the bone with the blade, you eliminate the periosteum and everything is done. You can close the flap because you have no possibility to obtain new keratinized tissue. Perfect. And then go parallel to the tooth. Perfectly. Exactly. I do a little bit more,
Yeah.
because the mesial incision is not not like this, but yeah, you have to go a little bit deeply with this incision. Okay, okay. So now you are able to fix it to the periosteum. Perfect. Yeah, but you haven't done the 2 vertical incisions. Do you remember? There is one vertical incision in the mesial part and one in the distal part. Yeah, and you have to do it at the beginning to obtain the correct height of the tissue. Probably there could be a little bit more line. Yeah. Okay.